Okay, welcome everyone. Good afternoon. My name is Catherine Alfano and I'm the American Cancer Society's new Vice President for Survivorship. I'm excited to welcome you all today to this really important webinar on cancer rehabilitation. So I'm going to take the liberty of starting us off today just with a few slides to set the stage for what we're talking about today. So as we all know, thanks to multimodal treatments and earlier detection, the number of cancer survivors in the United States is increasing dramatically. And that's actually not the full story, because what we're going to see is a tsunami, I call it, increase in the number of older adult cancer survivors. So between the years 2010 and 2020, the number of cancer survivors who are over the age of 65 is going to increase by 42%, which is really a dramatic increase in that number. And the reason why that's important is because our older adult cancer survivors come to us with all kinds of comorbidities and different kinds of problems that aren't as present in our younger cancer survivors. So, of course, every cancer survivor is at risk. They're at risk for the things in blue, the chronic effects of cancer. These are the things that are present when treatment ends and persist months and years sometimes after the conclusion of cancer therapies. And that's just because that's all the further out that we've researched them. So these are things like the mental health aspects, the depression and anxiety and relationship changes, fatigue we know is a big one, neuropathy, the pain syndromes, lymphedema, other kinds of physical impairments. And then cancer survivors are also at risk for late effects of cancer therapy. Those are the ones listed in red here, the ones that are not present when cancer therapy ends, but pop up seemingly out of nowhere. These are things like the congestive heart failure that comes from some treatments, or different kinds of bone loss and osteoporosis, certainly that recurrence that we're all worried about, or second cancers. But what I'm particularly worried about as a rehabilitation professional is this decline, this accumulation of functional limitations and functional impairments that makes cancer survivors spiral down into disability and the loss of independence. And that's what we want to avoid. Now, also, these aren't just older adult cancer survivors we're talking about. These are our baby boomers. And they have different expectations for what adequate physical functioning means. So when my own grandmother was diagnosed with breast cancer, she was a two-time breast cancer survivor, her physicians thought, you know, if they returned her to the physical functioning on the left here in a wheelchair, that was okay, because she was an older woman and that was adequate. Of course, she was a feisty lady, so that did not agree with her. But our baby boomers are not going to stand for that. They're going to be more like this gentleman on the right, who, if you can't tell, is a gentleman in his 80s, perhaps even 90s, who is water skiing barefoot. So our baby boomers are going to be asking us to return them to their water skiing, their rock climbing, their whatever activities they're out there rabble-rousing and doing, and we need to do that. So the U.S. is really talking about developing a better model, a new model of cancer survivorship care, and we now have several Institute of Medicine reports and Livestrong essential elements of survivorship care that all talk about what this should be. And it has to, this model of care has to deal with the dramatic increase in the number of cancer survivors, especially older adults who have these multiple comorbidities. And it has to address those comorbidities because in many cases, these cancer survivors are going to wind up dying of the comorbid conditions, not of their cancer. So we also have these chronic effects of treatment, and they're at risk for the late effects. And we know from the Institute of Medicine panels that the physical and emotional needs of cancer survivors are not being met. We really have to prevent that spiral into disability that I was talking about and promote healthy behaviors. So the Institute of Medicine in 2005 came out with this report, From Cancer Patient to Cancer Survivor, Lost in Transition. And really what it's about is defining these 4 pillars, we call them, of survivorship care. You need that surveillance for recurrence, for second cancers, for late effects. You need intervention for the treatment, the problems that treatment has caused, whether those are medical or psychosocial or economic. You need prevention, certainly, of recurrences, prevention of second cancers, prevention of those late effects or the exacerbation of comorbidities. And it also needs to be, the care needs to be coordinated between primary care and all of the kinds of oncology and rehabilitation specialists. So we really feel like the best model of care to think about as you're thinking about how can we look toward a model of care that meets all of our cancer survivors' needs is a comprehensive rehabilitation model. And why do I say that? Well, first of all, rehabilitation by definition has a joint focus on optimizing treatment of impairments and optimizing functional status and also quality of life. And there's also, of course, an intervention component. You're going to address pre-existing or treatment-related comorbidities. You're going to treat those chronic effects of cancer therapies that we're worried about. There's also a prevention component, and this includes promotion of self-management to the extent that people can, and promoting health behaviors to prevent further problems. Cancer rehabilitation is also coordinated. So it really takes a look at someone and says, what are the sum total of problems that is wrong with this person, and how do we coordinate care to fix these problems, to prevent that spiral into disability, to preserve the ability to work or to care for children or aging parents or whatever people need to do in life. So all we really need to do is add in that component of surveillance, and we have those 4 pillars of the institution of medicine survivorship care definition. So with that setup, I'm really excited to have Dr. Julie Silver on the phone with us today. She is an associate professor at Harvard Medical School in the Department of Physical Medicine and Rehabilitation. She's also a breast cancer survivor. Following her acute treatment for cancer in 2003, Dr. Silver realized there was a large gap in helping survivors to heal as well as possible from toxic cancer therapies. She wanted to promote understanding of the healing process and also help survivors function at the highest possible level. So she wrote the book, After Cancer Treatment, Heal Faster, Better, Stronger, which offers a step-by-step plan for physical healing from cancer treatment. I'll note Dr. Silver is also the editor of our American Cancer Society's book, What Helped Me Get Through, Cancer Survivors Share Wisdom and Hope After Cancer Treatment. Dr. Silver has published extensively in the area of oncology rehabilitation and cancer survivorship. She's on the medical staff at Massachusetts General, Brigham and Women's, Spalding Rehabilitation Hospitals in Boston, Massachusetts. She's also co-founder of Oncology Rehab Partners. As a doctor specializing in rehabilitation medicine or a physiatrist, Dr. Silver is uniquely qualified, and I know she's extremely committed to promoting and developing superior oncology rehabilitation services for cancer survivors. She lectures extensively to healthcare providers around the world about the need to create survivorship as a distinct phase of cancer care that includes oncology rehabilitation services. And with that, I'm going to turn us over to Dr. Silver.
Well, thank you, Dr. Alfano. This is fantastic to be on this webinar, and one of the things that many of you probably don't know is that there are hundreds of participants on this webinar, actually sites on this webinar, and probably thousands of participants, which is a huge change from what has happened in the past in terms of the interest in cancer rehabilitation and the vision to really see that we need to start treating patients very differently than we have in the past. So I want to really talk about the objectives here and meet the objectives that we discussed before the webinar. But I'm going to break this down a little bit into several parts and focus first on exercise, wellness, and impairment-driven cancer rehabilitation, because these are very different concepts. And many people on this webinar are really focused on impairment-driven cancer rehabilitation, and many others are focused on exercise and wellness. And both are really, really valuable and really important, but very different. So I want to start with what is the difference between these, and you know, these are part of the same family. We work together, really valued members of the survivorship team and so on, but it's different. These are like apples and oranges, and we want to include both but recognize that they have significant differences. Even among exercise, it can be very different. We know that exercise is good for people, but not all apples are created the same, and not all exercise is created the same. So let's take a look at a couple of exercise examples. The American College of Sports Medicine and the American Cancer Society developed a cancer exercise trainer, a CET certification, which is great. And Livestrong also developed a YMCA fitness for cancer survivors, and this is a fitness certification. And so these are two very different models. They both have value, but you'll see that the training is significantly different, and not all exercise is created equal. Impairment-driven cancer rehabilitation is a medical model, so this is different than out in the community fitness, wellness. This is really a medical model, and it does include nursing and lots of other healthcare professionals, and want to make sure that people recognize that there's many years of formal training and so on, and that what we're really focusing on are impairments. Now, for those of you that are interested or you're healthcare professionals in rehabilitation medicine, you might be wondering, well, why isn't she talking about function and the ICF, World Health Classification and so on? And the reason is because when talking to oncology audiences and oncology healthcare professionals, they really understand this idea of impairment-driven cancer rehabilitation much better than they understand some of the rehab lingo or even jargon that we talk about in terms of function, participation, and so on. So when we start talking about impairments, people on the oncology side really understand this. They understand that there's a lot of impairments in cancer survivors that are currently going untreated, and that they actually need a medical team to treat these different impairments. So let's look at the scientific literature that also, by the way, uses the term impairment. And we look at a study of 163 women with metastatic breast cancer. What % of these patients had impairments? 92%. Wow, that's a lot of patients. And then how many total impairments were documented? 530. So if there's only 163 women and there are 530 impairments, we know that many women have more than one impairment. And then what % of women receive treatment? Cancer rehab, less than 2% as outpatients, which is where most of the cancer rehabilitation and oncology care is offered on the outpatient side. So as Dr. Alfano was pointing out, we're going to have a tsunami of older cancer survivors. So let's look at a brand new study. This is brand new, just published, and it looked at 529 older adults with cancer. How many of these patients should have been sent for OT and PT for their functional deficits? 341, so 65% had potentially modifiable functional deficits and needed PT and OT. And then what % received PT and OT? So here we are in 2015, brand new study. We say, wow, less than 10%, only 9% received these services. This is what we call a very big gap in care. So we have identified needs, but we're not delivering the services. And these, again, are medical services. This is medical treatment. So I teamed up with the American Cancer Society and published a review with some colleagues, Sam Mayer, who's a physiatrist at Hopkins, and Jennifer Bema, who is a physiatrist with me at Harvard Medical School. And we published Impairment-Driven Cancer Rehabilitation, an essential component of quality care and survivorship. And what happened from this review article that we published is many people read this, and many oncologists read this. And the American Cancer Society said, we're going to take that term, impairment-driven cancer rehabilitation, and we're going to put it in our facts and figures. So for the first time ever, cancer rehabilitation was introduced into the ACS's facts and figures. So kudos to the American Cancer Society for being progressive and proactive and actually including cancer rehabilitation in the information that they give to survivors and many others that are looking at those statistics. So what do the best practices cancer rehab model look like? It looks like physiatrists are involved, PTs, OTs, speech-language pathologists, working with nurses and dietitians, mental health professionals, and so on, and also working with fitness professionals. And there needs to be a nice handoff to fitness. And looking at where the impairments get treated, they get treated in that green box. They get treated, this is medical care, and they're treated in medical facilities and in clinical care institutions, and then they're handed off to fitness professionals. Now, both of these models work, and that's important to remember. Both models work, but only if the patients are screened and triaged. So according to the scientific literature, what % of cancer patients will have impairments and need the model on the left? That's going to be about 65 to 90%. And when you look at the model on the right, how many need that? Well, more than 90%. So, you know, we definitely want to hand off patients, you know, to have fitness. So, you know, in terms of the model, I actually misspoke and said that 65 to 90% have impairments, and I didn't mean to say that more than 90% should be handed off straight from the physician to the fitness professional, but what I mean by that is that fitness is really important in general exercise in more than 90% of the patients. So the vast majority of patients are going to benefit from general exercise and wellness. So for all of you that have focused your careers on general exercise and wellness, really important, super important work that you're doing. And for all of you on this webinar that have focused your career on impairment-driven cancer rehabilitation, you're also doing really important work, and we need to insert you more into the care continuum. So high quality cancer care, what does this really look like? It looks like new cancer diagnosis, prehabilitation, which we'll talk about a little bit, then acute cancer treatment, screening to decide whether people have impairments or not, and then if they do have impairments, they get rehab, and if they don't, they go straight to fitness. So what does the science tell us? There's about, you know, if you have 10 cancer survivors, then 1 out of 4 would be apple only or general exercise and wellness only, and 6 out of 9 would be orange and apple. Sometimes when I talk to different healthcare professionals and I say if you had to err on the side of caution, send them to rehab because most of the time you're going to be right and they're going to have problems. What happens if survivors who have impairments don't get rehabilitation? Well, there's a lot of problems. They have impairments that build up and increase in severity and in number. That leads to disability. So remember that impairments are those things that we see on physical examination, and disability is what you can't do because of the impairment. So that leads to increased disability, time off from work, increased costs, affecting the patient, affecting the family, affecting the workplace and society. So a lot of issues. And this unnecessary disability is really, really important to address. With cancer, there's a lot of pain, there's a lot of fatigue, there are a lot of impairments, and there's a lot of disability. So what I'm talking about is the unnecessary part of it, the unnecessary part that we have trained rehabilitation professionals who can help with. So let's talk a little bit about this unnecessary part because I think it's really important. And one of the things that I talked to Dr. Alfano about before this webinar is I said I'm going to bring up the oncology care model, which is a CMS model that they're testing with Medicare and so on, looking at this idea of an oncology home and that the oncology healthcare professionals own that patient for a period of time and everything that happens to that patient. So next year in 2016, what's going to happen is they're going to pilot this idea of an oncology model, and at the beginning of chemo, so when the chemotherapy starts for 6 months thereafter, the healthcare professionals own whatever happens to that patient during that time. So if the patient develops neuropathy and falls and has a hip fracture, that cost counts against them. If the patient has various problems like I'm going to describe here in these cases, that counts against them. If they have a workup, a metastatic workup that happens to be negative and they're really doing a metastatic workup for a musculoskeletal problem, that counts against them. So, so I want you to just kind of be thinking about that as I go through this case and think about, wow, as the risk shifts, and now it's not fee for service as much anymore. We don't get paid for every single procedure we do, every single thing we do, but it's an episode of care. And if that episode of care is 6 months of chemo, then what does that look like? How are we going to identify the potential problems that somebody may have, like a fall with a hip fracture or a metastatic workup that really doesn't need to be done and so on? And how are we going to reduce costs and have better outcomes? So here's Mary, and she's pretty typical 55-year-old woman. I see a lot of Marys in my practice, and for those of you that are doing cancer rehab, you're probably seeing lots and lots of Marys. And she, underwent quite a bit of treatment, and now she's on an aerobic inhibitor. So I'm going to go through a couple of scenarios. First of all, Mary has never been screened, so we really don't know what her, what her musculoskeletal status was and what her shoulder pain and so on was beforehand. And here she is complaining, and she's saying that she rolls on her affected side and she can't sleep and she's tired in the morning and she can't really do a lot of ADLs, functioning and so on, or ADLs. And so here's this question, do we need to do a metastatic workup on Mary? Now, when I ask oncologists this question, most of them will do the metastatic workup. And I agree with that because we really don't know if this is metastasis at this point. We don't have any kind of baseline. So the answer is probably. What's the most likely diagnosis? Probably rotator cuff impingement, adhesive capsulitis that's progressed. What treatment? Well, early on, it would have been great to send her to physical therapy. At this point, we're looking at probably physical therapy, possibly subacromial injections, and even manipulation under anesthesia, which is an orthopedic procedure. What could have been done to prevent this? Well, certainly a baseline assessment and early intervention on the rehab side. So this is, these are actual numbers that I got from hospitals that I work with, looking at what would happen. So here we have no prehab. She goes to adhesive capsulitis, which for those of you in rehab, you know how difficult it is to treat adhesive capsulitis versus early rotator cuff impingement. She's left with permanent disability, and it takes her a year to go back to work. And the total direct cost for that, including this metastatic workup, is almost $6,000. And that doesn't include going to the operating room for manipulation under anesthesia. So now she gets prehab, and all of a sudden she's returning to work in 6 weeks, and the total direct cost is a lot less. So keep that in mind as we see the risk shift, and healthcare professionals have to take on more responsibility and more risk for ensuring outcomes. These are important types of things to look at. Here's a question, though. Mary works in an office job. So why does it take her so long to return to work? If the rotator cuff really engages at about 90 degrees or so, and most of her work is below the level of 90 degrees, and she's really not having pain at work, and she really can function at work, why isn't she? And that brings us to the classic symptom cluster of pain, anxiety, insomnia, and fatigue. And we see these symptom clusters over and over again. They're well documented in the medical literature. And often there's a sentinel symptom. And in Mary's case, it's pain. If she didn't have pain, then she could probably sleep through the night. She wouldn't be anxious. She wouldn't be on the internet searching and saying, oh my goodness, night pain is a red flag. My cancer's probably back. I can't sleep. I'm really worried. And then waking up very, very tired and not able to go to work and function. So Beth is another case. Beth is similar to Mary, and Beth is now complaining of pain on her elbow on her unaffected side. So this is her unaffected side. This is different. And she's dropping things, and it hurts to use the mouse on the computer and to hold her cell phone. I also see a lot of Beths and I'm sure that many of you see Beth. So the last Beth I saw, my medical assistant said to me, she's really, really anxious. Before you go in there, I just want you to know that she's insisting on a metastatic workup. So I go in, and of course, there she is having pain on her unaffected side, very consistent with a lateral epicondylitis, and she's insisting on a metastatic workup. And quite frankly, she ended up with a metastatic workup because, you know, we didn't have a baseline, and you know, she was very, very determined to have this. She'd been reading on the internet, all kinds of things, and so on. Now, why is this on the unaffected side? This is really important. The reason that we see so many problems on the unaffected side is because the affected side never had rehab. And so they guard and they protect on the affected side, and they overuse their unaffected side, and they get lots of overuse problems. So very, very common to have, you know, this is basically a tennis elbow on the unaffected side that could have been prevented and ended up with a metastatic workup for musculoskeletal problem. Really easy, straightforward, you know, problem. We could have prevented this completely if we would have just rehabbed her affected side. So Juanita, she's similar to Mary and Beth, and now she's 6 months out here, and she's complaining of her thumb getting stuck. And this is actually a real case, and we wrote this case up, and this is on her non-dominant hand. Here's what happened with Juanita. She's pretty interesting. What happened is that she went on the internet, and she went on these chat groups, and she started reading about aromatase inhibitors. And she was reading on the internet that aromatase inhibitors can cause not only arthralgia, but also tendinopathies. So she went to her oncologist, and she asked her oncologist, and her oncologist said, no, they just cause arthralgia. Your thumb getting stuck and you having problems is really not related to them. So she came in to see me, and she said, here I am on the internet reading these things in these chat rooms from these cancer survivors, but my oncologist says, no, that's not true, and I want to know what is true and what is really going on, because I can't work. I'm a portrait photographer, and I do lots of school pictures, and I have to use the computer and use the mouse and so on to get rid of all the blemishes and pimples and everything else on these high school students. And when my thumb gets stuck, I really can't work. So does she need a metastatic workup? She absolutely had one before she got to me. She has more than one diagnosis. She has 2. The tests, we could definitely order a number of tests, but this is a pretty easy diagnosis clinically. So thumb getting stuck is a trigger finger, and her fingers feeling numb and tingling on the dominant hand in a median nerve distribution is carpal tunnel syndrome. Why is she having these problems? Because aromatase inhibitors cause tendon issues. And if you know that, then you'll say, okay, that makes sense for the trigger thumb, but why is she getting carpal tunnel syndrome, which is median neuropathy? And that's because you have to know what travels through the carpal tunnel with the median nerve, a bunch of tendons. So as the carpal tunnel gets tighter, because these tendons are now having problems and more inflammation and so on, the nerve is getting compressed. Pretty straightforward diagnoses, but you need to know what those are. So one of the questions in the oncology care model that CMS is developing, one of the FAQs that the American Cancer Society can send out to you all later if you would like it. They'll send an email to you with more information and so on. But one of the FAQs asks whether the aromatase, whether patients on hormonal therapies, including androgen deprivation therapy and hormonal therapies like aromatase inhibitors, will be counted. And the answer was yes. So those problems that patients seek medical treatment for, and those metastatic workups and all of that, are going to be counted in this trial. How many impairments did we just discuss? Well, a lot. You know, we discussed a lot of different problems. And there's a lot of potential impairment in these patients. And again, this is medical treatment. And you see these codes on here. And what a lot of times people ask me is they say, just give me the list of codes. And I say, wow, you know, if you just have a list of codes and you don't know how to treat these appropriately and you don't know how to document properly, that can get you into a lot of trouble. So make sure that when you're using codes that you actually are trained to treat these medical conditions and that you're documenting properly, because it's not really just about knowing the right code to use. So distress and quality of life, let's talk about that, because a lot of people on this webinar are very interested in quality of life issues. They're very focused on mental health and distress and how does this play into it. And I could put up study after study after study showing the really close relationship between distress and physical function, quality of life, and so on. And one of the things I really encourage people to do on the mental health side and also on the physical health side is to be looking at the studies that show these relationships. And we know that more cancer survivors are distressed due to physical problems than emotional ones, but it decreases health-related quality of life more often because of physical issues than emotional ones and so on, and that there's this very, very strong relationship. And we want to treat both, frankly. So quality of life, one of the things that frequently is missing from this quality of life umbrella is cancer rehabilitation, but it's under the same umbrella that all these other wonderful services are under, and we just want to make sure that we put that orange in the fruit basket and that it's consistently offered to the patients that really need this care. So let's talk about that. You know, medical care delivery, quality, safety. Safety is a big issue in cancer rehabilitation. Adrienne Christian is the first author on this paper, and when I gave rounds at Kingsbrook Jewish Hospital in the Bronx, which is where he is, and I put this up, he got a standing ovation from the doctors in the room for this, because this is a really big issue. These patients are sick, they have comorbid conditions, and safety is a very, very important issue in cancer rehabilitation. And we know this, too, from looking at various studies on fitness and exercise and so on. And when you look at this, you know, 20.9% in the weightlifting group had an encounter with a healthcare provider that required cessation or dose modification of weightlifting. Remember that the transfer of risk to healthcare professionals means that all those visits get counted against the providers. So impairment-driven cancer rehabilitation really looks like this, you know, where you have the most control and the highest quality is going to be from the medical team that is trained to treat those impairments. On-site fitness and exercise programs are terrific, and then you lose a lot of control in the community, which doesn't mean that patients shouldn't be getting services in the community. Of course they should. Of course we want to develop great community services, but we have to be very cognizant of the medical model that is now really focusing on accountability and treating impairments and making sure that these patients are ready and able to function well in the community. So high quality cancer care delivery system has patient-centered care. Those patients are right there in the center. You know, the workforce is trained around the patient. Clinicians are focused on these quality measurements, and we're talking about reimbursement models and so on, and there's a number of different stakeholders in this, including the patients, the doctors, and the payers. So let's talk about access to care, screening, referrals, and reimbursement. And when we look at this, it's really important to know that that the Commission on Cancer has, as an eligibility requirement, cancer rehabilitation. And a lot of people think that's new, but it's not. It's been an eligibility requirement for a long time. What is new are these new standards, 3.1 and 3.2 and 3.3, and that's really driving cancer rehab. But here's the interesting thing, is that COC surveyors in the past basically said, you know, just let me know if you have cancer rehab services on site. And what happened was a lot of boutique cancer rehab programs were set up, and they would have wonderful clinicians and wonderful outcomes for these few patients that were referred. But the COC surveyors never said, well, gee, how many impairments do this population really have? 65 to 90% or so. How many of these patients are actually getting referred? Ooh, less than 10%. Wow, there's a big gap in care. What are you doing to actually get these patients access, all of the patients that need this care? So instead of having boutique little cancer rehab programs, now what the COC surveyors are saying is, show me your gap in care. Let's talk about that. And it's an easy equation to do. You basically go to your cancer registrar and you say, how many annual analytic cases do we have? You go to your rehab director and say, how many cases were referred? And you do the math, and it's a very simple math equation. We want to be focused very early on these patients that, for example, are getting surgery. We know that they are very frail a lot of times. They're older, and we have a problem with getting them through surgery. So one of the first things that we can do is really identify, like, who are the patients at the greatest risk? Are we able to help them with rehabilitation or other interventions? Can we improve outcomes, and so on? Now think about this. This is actually Franco Carli and his group in Montreal, and he's done a lot of great work on cancer prehab. And I love what they wrote here because it's really important. Franco Carli and I have talked a lot about prehab. And he wrote, tissue trauma, physical inactivity, quasi-starvation, and psychological distress represent major stresses to the body. So here you have this person who you're going to operate on and cause tissue trauma. They're going to be physically inactive. You're going to starve them before surgery, literally starve them before surgery. And they're going to, of course, have a lot of psychological distress. And then you expect them to do really well. Well, of course that's not a setup to do well. So in the early prehab protocols, what they did is they said, okay, we are going to do exercise. But guess what? There were problems with that because all you're doing now is the exercise part, which would increase the catabolic state of the patient, and then you're starving them. And they're still really distressed. And we weren't having the kind of outcomes that we really wanted to see. So prehab in general has moved to multimodal care with protocols and really understanding that it's very different than just telling patients you need to eat better or you need to exercise more before your surgery. It's designed to drive very specific outcomes. And if you don't measure the baseline, you don't even know what outcomes you're getting. But cancer prehab is not usual care, and it's not handing somebody a list of exercises that they should do or telling them to eat better or giving them advice like that. The nutrition component, it really has to do with protein supplementation and glycemic control. So as we look at the new cancer diagnosis and prehab assessments and so on, of course, if they have physical or psychological problems, get them to the right healthcare professionals. If they don't, put them under your prehab protocol and start driving your outcomes. Even if they do have these problems, you should put them in your prehab protocol in most instances too, but get them that additional help. So prehab, this is a game changer actually. This is really interesting. In some populations, we think that, and we have early evidence to show that prehab could change outcomes so that patients are actually healthier after cancer treatment than they were before. Now imagine that, because patients are so often told that they need to accept a new normal, which means that they're way down there at that red line, you know, at the end, that they're you know, not even at baseline, and that's their new normal. And imagine if we told them, wait a second, you actually could be better than you were before, because we're going to start early, we're going to get you really geared up for your operation or your chemotherapy or whatever, and we're going to really drive good outcomes. The reimbursable part of cancer rehab is everything except the general exercise component. So almost everything is covered care except the general exercise component. So this is really important right now for healthcare professionals to realize that this care is covered. There are some caps, and one thing that the caps really mean is that you have to identify problems earlier and treat them for fewer visits, and that makes a lot of sense. I often hear people say things like, well, I treat patients with skin cancer, melanoma, and they really don't need rehab. Or I treat just patients with thyroid cancer, and they don't really have impairments. And one of the things that I really try to point out is before you make assumptions, be sure that you're solid on the science. Be sure that you've really researched the literature and that you really know what impairments your patients may be having. This is a brand new study. It's ahead of print here as an EPUB, and this is thyroid cancer. And one of the things I wanted to highlight here was just that that these patients have persistent restrictions in regaining their normal daily life in terms of work and leisure. And that this is, despite a very good prognosis, they're still really struggling. So don't make assumptions about what you think might be happening. Be solid on the science and go to the medical literature. I've written a lot about dual screening. Dual screening really focuses on physical and psychosocial well-being, making sure we understand what's going on with our patients. When I talk about dual screening, a lot of times because distress screening and the distress thermometer has been such an important thing that many hospitals have adopted, people are looking for the one screening tool that will just fix everything, or the one intervention that will fix everything. And I often say it's sort of like asking, which chemotherapy drug can we use to cure all cancer? We don't want to do surgery, we don't want to do radiation treatment, we don't want bone marrow transplants, we just want that one chemotherapy drug. So if you ask me, like, what's the one thing that we can do to sort of make all this work, I will say that it's much more complicated than that, and that's really not the right question to be asking. The right questions to be asking are, what patient population are we talking about? What kinds of treatment are we talking about? What kinds of things can we anticipate that we know from the medical literature already? And then what's going on with this particular patient? So looking at dual screening versus no screening, and it's much better. So let's look at reimbursement. I told you that there are caps, and many of you know that. On the oncology side, what a lot of people don't realize is that whether you have had a sports injury, you're in a car accident, you had a stroke, or anything else, including cancer, that the care is reimbursed under these buckets. And this is Medicare. A lot of other payers go by Medicare. And if you document medical necessity, which you almost always can, you get more money. So the old standard of care was that people would wait, they wouldn't screen the cancer patients, and the impairments would build up, and they would end up with lots and lots of problems. And then they would finally be sent to rehab, and then the rehab clinician was supposed to fix everything in a very few visits. And that's really not going to work. And so the new standard of care is we have to refer a lot more patients for rehab, and we want to make sure to treat them for fewer visits. So we've got to pick up these impairments early and get our rehab teams up to speed with treating them for just a few visits and making sure that we identify all the patients that need this care much earlier. And this fits in with the Institute for Healthcare Improvement, the Triple Aim. And even if you haven't heard the words, the Triple Aim, you've probably been hearing about what the Triple Aim represents. And what the Triple Aim really is trying to do is it's trying to basically say you've got to make the patients happier, you have to make them healthier, and you have to decrease the per capita cost. So you have to make them happier and healthier, but you have to spend less money doing it. And that is, you have to do all three of those things at once, and that is super challenging. But that is what healthcare is all about right now. And that means that we have to identify these impairments early, try to prevent some of the impairments. When we do identify them early, treat them efficiently and effectively, and so on. This is Dr. Tim Sherwood. He's a thoracic surgeon at Mary Washington Healthcare, and he is a big fan of prehab, and he has discussed this a lot and really focused on lung cancer prehab, which the literature is pretty strong on in terms of prehab literature. And this is Alberta, and she is a patient of his who has done extremely well with prehab, and is one of those patients that was better after cancer treatment than she was when she started. And this case was written up by the team at Mary Washington Healthcare. And this is an example, and there are numerous other examples of these patients actually being happier, healthier, and doing better, and not having catastrophic problems in the hospital. So this is a health system, and just to show you, what it looks like when you move away from a boutique cancer rehab program to an actual service line, and you're really starting to focus on treating all of the patients or most of the patients that need this care. It brings a lot of revenue into the hospital, and you get a lot more patients over there. And that penetration rate is really important. That is, that's that number that I was saying. You ask your cancer registrar, how many new analytic cases do we have? You ask your rehab director, how many patients were referred for rehab? And you look at what that penetration actually looks like. And it can be done. I've worked with numerous hospitals and healthcare systems that are doing this all around the country, and it's really important to know that some hospitals and some healthcare systems are able to do this, and yours can too. So what are the doctors saying? This is always something that I think is really important. Many doctors, I talk to many doctors, and they say things to me, but they don't really have a chance to tell others. And so I wanted to just share what their thoughts were. So Barry Brooks, you see, he's really telling his oncology colleagues to step up. He's really saying, listen, no oncologist should allow patients to suffer needlessly. That's really important. And Michael Seiden, he's a former president and CEO of Fox Chase. He's saying, too, it's time that oncologists engage with experts in cancer rehab to better predict which impairments might arise or alternatively have occurred, and plan for this. So, really understanding that this has to start on the oncology side. And then Andrea McKee, she is the chair of the Department of Radiation Oncology, and she's a big fan of lung cancer prehab, and this ties into the new screenings for the CT screenings for lung cancer, the lung screenings that are going to pick up a lot more early lung cancer. So we're going to see a big jump in the number of people diagnosed with lung cancer at an earlier stage with these new screenings that Medicare announced, I believe, in November of 2014. So here we have survivorship care. We have all these other things that are really important. This isn't meant to be, the total picture. There's a lot of things that aren't in this puzzle. But cancer rehab is a missing piece, and we want to include that as a central piece of something that will really help improve outcomes. I do want to just share with you all that you can send us questions in the Q&A part in the chat box. So just send us questions if you have, and we will answer them in a couple of minutes. So next on the horizon, there's a lot of exciting things happening, and it involves all of you on this webinar and many of your colleagues. And I know many of you are listening in to be the people that relay information back to others. And I think that there's, it's really important to say that cancer rehabilitation has really arrived, and that people are taking this very seriously, and that we know that it's going to help improve outcomes, and that we have to be really smart about the way we deliver this care. So the NIH and the National Cancer Institute have identified cancer rehab as an undeveloped, or underdeveloped rather, area. And they brought together a number of subject matter experts, including me, and Dr. Alfano is participating as well, and so on. And we've been working for months on different components of cancer rehabilitation and what needs to be done in the future. And then there's a dissemination conference that is June 8th and 9th, and this is a free conference. All of you can attend, and all of your colleagues can attend, and we want you to attend. And this conference is really to be a handoff to those of you that are on this webinar and those of you that are involved in survivorship care, to say, okay, here's what these groups of experts that have come together and been working for the better part of a year are recommending. And you and your institution and your work and so on, can help to lead the way. we've been talking internally about this a lot, and one of the things that we've said is it would be interesting to see what that handoff looks like. Like, who's going to really lead the way? Will it be, for example, the American Cancer Society? Are they going to really get behind cancer rehab? My guess is yes, because I'm here on this webinar talking to all of you, and this is sponsored by the American Cancer Society, and I think the American Cancer Society has a real vision for cancer rehab. And Dr. Alfano herself has a real vision for cancer rehab. She's new to the American Cancer Society, just coming over from the MCI. So my guess is the ACS is going to do a lot. I think there's other groups that are going to do a lot too, and I'm not sure which ones they are. I think there's hospitals that are going to lead the way too, and I'm not entirely sure which ones those are. Some of them I already know, but some of them I don't know. So it's going to be really interesting to see what happens after we hand off these recommendations and we talk about very specific things that need to be done. Who's going to lead the way? Thank you so much for listening and being here, and I definitely want to answer any of your questions, and Dr. Alfano is available as well as we tee up the questions. But really appreciate your patience and you know, thinking about all of these important issues.
Thank you so much, Dr. Silver, for that great presentation. So for all of you who are still with us, you can go down to the Q&A box and send questions to us. Make sure you send them, it's down in the right-hand corner, and send them to all panelists, and then you can submit those to us and we can answer them. So Dr. Silver, I'm looking at one that is a question I know I get a lot, and I bet you get this a lot too. When looking at doing a prehab, pre-screening for newly diagnosed cancer patients, how do you bill if the patient's not having any current impairments? So it's that prehab issue. How do you cover billing for prehab?
So that's a really good question. First of all, there is no prehab code. And for those of you in rehab, I know you know this, but it's a really common question. Like, just give me that prehab code. There is no prehab code. Most patients are going to have some kind of impairment, some sort of problems ahead of time that you actually can code and bill for. In the protocols that I work on and that I work with hospitals on, they're multimodal, and so some of the components, most of the components you can bill for. Not all of them you can bill for. It depends on the different patient population. It depends on the components that you're adding to it, and so on. But generally speaking, we're finding in the hospitals that we're working with that most of it is covered. But you have to be careful about how you bill and code, and I really emphasize that, because you have to be ethical in what you're doing. But a lot of these patients are going to start with significant problems. If you look at, for example, a lung cancer population, it's highly unlikely that any patient who's diagnosed with lung cancer is going to have no impairments at all. The vast majority are going to have significant problems.
Thank you. So we're getting a lot of questions about will the slides be available in one-in copies, and yet we are recording this webinar, so you'll have access to that, and we're also going to send you out some information about some additional reading materials and websites to check out for those of you who want more reading. We're also getting some questions about when that cancer rehabilitation conference is that Dr. Silver referred to, that she and I are both involved with. That's going to be at the Natcher Auditorium, which is on the main campus of the National Institutes of Health, which is in Bethesda, Maryland. And that is an open conference, so you can go on, if you just Google it, you'll find that, and you can go on there and register for that. Let's see.
And we do send them the link as well. After this webinar, the American Cancer Society will send you an email with a link to the conference information as well, I believe.
I'm scrolling through questions here. We've talked a lot about billing. What about, I know another question that you get, Dr. Silver, a lot is, what about measurement? I'm seeing some questions here about measurement. What do you really use to do that screening assessment?
So that's a really important question, and in general, there's a lot of different ways to screen. And as Dr. Alfano and I were talking earlier, we said, you know, the work group that is focused on outcome measurement and so on and screening for this NIH initiative is very challenged because there's a lot of different instruments and tools and so on. And one thing that I really focus with in my work is not just saying, here, just use this screening tool, but really thinking about the patient population. So, and a lot of times that's diagnosis specific. So we're going to be focusing with the lung group on the lung patient, on the breast group on the breast patient. And then recognizing what are the most common problems that they're going to have. So, for example, in a surgical lung population, you're going to be really worried about, for example, pneumonia or surgical site wound infections causing hospital readmission. And you want to be thinking, what are those things that will decrease hospital admissions for pneumonia and surgical site wound infection? In a breast cancer population, you're not going to be very worried about that. Those aren't really big risk factors in breast cancer, especially pneumonia. Those patients are going to have many more problems with upper extremity issues. So it's not just one tool, it's really a protocol, and understanding what tools should be used, at what points in time should they be screened, who should do the screening, what happens when you pick up problems, how do those patients get referred, who do they get referred to, are those people trained, and can they see them for just a few visits, and keep the healthcare costs low, but give them excellent rehabilitation care and so on. So lots of things to be considering, and you know, outcomes and tools are part of a very, very, very important picture, which is what we titled this webinar, Comprehensive Cancer Rehabilitation.
So another question coming in, it would be good to hear more about how this model of care saves money rather than generates new revenue.
Right. So the idea, keep in mind that there's a lot of different models of care that are being tested to try to save money. And the overarching focus is that instead of basically hospitals and healthcare professionals saying every time we order a test or every time we see a patient, we're going to get paid. What the third-party payers, including Medicare, are saying is that since you control the delivery of these services, when you order tests and do all of these different things, then you need to figure out the way to save money. So they're putting the risk back on the healthcare professionals in the hospitals. And one of the ways they're doing that is this sort of episode of care idea, where they'll pay a fixed amount, and then you own the expenses within that fixed amount. So you've seen this before, for example, with patients that are under DRGs for surgery or whatever, and you know, if the patient stays 2 weeks or if they stay 2 days, you still get the same amount of money. So there's a lot of these shifts that are happening, and these pilots that are being tested in bundles and all kinds of different ways. And we're going to see more and more of that. That is the way that healthcare is going. And so you have to think about, all right, what are the things that really cause patients to have significant problems? Tests they don't need. Hospitalization, so the number one thing, the absolute number one thing that costs a lot of money is an unanticipated hospitalization. Probably the number two thing that costs a lot of money is an extended hospital length of stay for complications. The number three thing is probably the unnecessary tests that are done, for example, metastatic workups for musculoskeletal problems. When you look at rehab, well, certainly if you offer tons and tons of rehab to every patient and they just, were inundated with rehab, that would cost a lot of money too. So being strategic about how you deliver rehabilitation services, picking up impairments early, treating these patients early, avoiding some of the other problems like they fall down and have a hip fracture, which requires a hospitalization and all kinds of things. So we're going to have to, as a rehab community, we're going to have to really
analyze our own outcomes and really look at the care we're delivering and make sure that we are very focused on the value proposition for cancer rehabilitation. But everything, or nearly everything, suggests that cancer rehab is going to be a huge part of this transition because that's the only way to really improve the outcomes.
Dr. Silver, we have time for one last quick question, and I want that question to be this one that just came in. How do we better educate physicians about the importance of rehab and impairments? And this person means the oncology team.
Right. So we do it together. It's not just one person or one way. I think that all of you that are on this webinar have voices, have connections, have a way to go back and talk about what you learned on this webinar, to talk about this conference that's coming up, and so on. We know that it's going to take time to educate oncologists, but one of the things that I wanted to point out, and I pointed it out, I'll go back and just show you the slide here with the oncologists. You know, a lot of these oncologists are already educated. They're waiting for rehab to step up, and they're waiting to go beyond these boutique little rehab programs. And they're saying, like, how do I get my patients in? How can you implement screening? And not just get my patients in, but I want to see the results. The oncologists have been saying to me again and again, I want to see the results, and not just in jargon-filled notes that I don't understand. I want to actually see the results. This is really important because at the end of the day, the oncologists own these outcomes. You know, we think of them as rehab outcomes, but they really aren't. Our outcomes in rehab medicine are part of the oncology care continuum, and they're part of these oncologist outcomes, and they're part of the oncology service line. And so we have to start getting oriented that way and thinking, okay, if they are part of value-based care and they own these outcomes, then they want to know what those outcomes look like, and they want to have the confidence that we're delivering great care, and we're only delivering the care that's necessary and appropriate. Dr. McKee, on the bottom left there, says, you know, prehab is part of patient-centered care, and one of the first things patients ask her is, you know, what can I do to help myself prepare for treatment? And she says, you know, here that patients already intuitively understand that prehab will benefit them, but it's taken the medical community a little bit longer to catch on. And that is really true. You know, the oncologists are really shifting gears and really starting to catch on, and we need to keep talking about this, encouraging this, but also be responsible clinicians that are providing the outcomes and being strategic and appropriate in the delivery of care.
Well, thank you so much, Dr. Silver, for a great webinar today. Thanks to all of you for joining us, and please let me tell you that as you're signing off, you're going to have a few questions, some survey questions to fill out. Please do fill those out for us because we do use those data. Thanks to all of you. Bye-bye.